Good afternoon, everyone. Welcome to day 3 of the Pacific Update, and this is the final session of day 3. I'd like to take this opportunity to welcome all of our participants who are joining us through Zoom, as well as those who are joining through Facebook Live. So the session, the last session is on health systems, and we have 3 great presentations lined up for this session. And I'll now hand it over to the chair of the session, Colin Wiltshire, who's a research fellow with the Department of Pacific Affairs, College of Asia and Pacific at the Australian National University. Over to you, Colin.
Okay, thank you for the introduction. Good afternoon all, and welcome to this health systems panel as part of the Pacific Update. A reminder that this session is being recorded and live streamed via Facebook. We're fortunate to have an experienced group of panelists for this session who will speak on a diverse range of topics. Our first speaker will be Dr. Neil Sharma, who is a medical practitioner based in Suva and the former Fiji Minister of Health. Dr. Sharma is an executive member of the Fiji College of General Practitioners and the editor of the quarterly online journal Pharma Times. Our second speakers will be Dr. Shane Stockil, who is the Country Medical Director for International SOS, and Dr. Natalie Gray is a public health physician and travel medicine clinician working with the International SOS. Our third speaker will be Simona Achitei, who is a grants and program manager with DT Global and project manager for the Pacific Island Food Revolution project, while Vang works at the Busara Centre for behavioural economics and specialises in behavioural and experimental economics and econometric policy evaluation. And so each speaker will have 15 minutes for their presentation, which will be immediately followed by 5 minutes of Q&A for that speaker or those speakers. And I encourage everyone to please ask questions. You'll have the opportunity to ask questions via the online chat function during the presentation, or you can raise your virtual hand at the conclusion of the presentation and I'll ask you to ask that question. So I'd now like to invite Dr. Sharma to make his presentation.
Okay. Yeah. Up to one. Good afternoon, ladies and gentlemen, colleagues, and other presenters. My topic for discussion today is strengthening fragile healthcare systems, and this is based on looking at things globally, but a narrative from Fiji. Now, we all know that resources are very essential in any healthcare system, and the impact of the pandemic has had sort of major impact on developing countries, and more so, we must not forget that even the most powerful people who spend sizable amounts of money in their towards their healthcare have also been affected. So it's important that we look at this, very objectively. Now, what happens is, if you look at fragility, fragility is a very subjective term, but I'll apply some WHO principles to be able to put some objectivity into what we are trying to say or do, and look at the health system in Fiji as such. The WHO has a 6 building block criteria, and that is presented to you on the screen: executive governance and leadership, workforce strength and capabilities, training, health service delivery, health financing, which is all important, availability of technology, and pharmacological and pharmacology and consumable supply chain being appropriate to be able to provide healthcare to our people. Let's look at the situation in Fiji, in an island state where it represents a low-income country. Fiji is regarded as a mid-level country now. And let's look at why Fiji's health system is fragile. We are in a archipelago of 330 islands, and 5 larger islands carry the bulk of the population. We have a population of 864,000 as per the recent Bureau of Statistics report. The indigenous population accounts for 62% of the population, Fiji Indians 34%, and other ethnicities 4%. The mean age of the population is 28 years, and we have a rural movement of people which accounts for 56% of the population. Maritime and rural areas only account for 44%. There is a shifting into the urban and peri-urban areas now. If you look at our peri-urban or squatter settlements, nationally, 10% of our people live in squatter settlements. In the capital Suva, close to 20% of people live in squatter settlements in improvised conditions of ways of life. Now, if you look at our health and GDP ratio, it is 2.8%, and WHO's regional criteria is more than 6.6%. The total health expenses per government expense is under 9%, and WHO's recommended figure is more than 14%. Our national lifespan for males is 64. Females outlive them by 6 years to 70. And if you look at the population over 60, only 8% of people live beyond 60 now, and it is projected that if all things were running in normal times, that would double by 2030 to 16%. 30% of our population were living below the poverty line pre-COVID, and as the reasonable estimates suggest that might have risen to about 50% now. Communicable diseases are endemic. We still have typhoid, we have leptospirosis, and we have dengue. These are very related to the weather. And we have a very high incidence of non-communicable diseases, which is responsible for 80% of premature deaths. And this is based on 2 WHO step surveys undertaken in Fiji. And interestingly, the Australian aid, working through the DFAT, has undertaken structural reforms. And these reports are being carried out in all of the Pacific Islands, in a sequential manner. And the last report was in 2014. Now, turning over to the next part is the impact of COVID on Fiji's healthcare system. The first wave, we were fortunate. There were 2 case fatalities. These were imported Delta variants. These were patients returning to Fiji. And the containment measures which were put in place was quite effective initially. However, with the second wave this year, since April, and looking at the most recent figures up to the 15th of September, we note that close to under 50,000 cases of positive COVID have been swabbed. However, this is now being undertaken rather selectively. And we also note that as of 15, there were 540 deaths, 374 associated deaths to COVID-19, a total of 914 deaths to date. If you look at our vaccination strategies, at this point in time, on 15th, 97% of the population had received their first dose. The second dose being received by just over 60%. However, we must note that there's been a sort of vaccine diplomacy has saw a slow start to the availability of vaccines, and the uptake was initially very, very slow. We were supplied with AstraZeneca vaccine, and more recently we've been given Moderna vaccines, which are available to aged people, to people with NCDs, and to pregnant mothers. There has been a political call for mandatory vaccination. However, no regulatory changes are being put in place, and this has been questioned by the public a lot more recently. The vaccine strategy needs to be elaborated to the wider community because of the uncertainty. People aren't sure. It's a new vaccine. And it's been developed very quickly. So people are still very concerned. People in the Fiji tend to, sort of avoid vaccination as far as possible, although we have a very high infant vaccination rate of, sort of successful vaccinations of up to 96, 97%. There has been a call to reopen our borders, and that's being debated in the social media quite effectively. Now, let's look at some of the issues we have. Now, all countries are dealing with a new virus. The virus is evolving, and the healthcare systems are being challenged, and strategies being put in place, being changed strategically because for various reasons, whether it's financial or knowledge-based. So really, at this point in time, if you look at what happened in Fiji, we put in a very effective containment program, but there was no backup as far as mitigation went. We thought we'd be able to contain it on the periphery. However, when it jumped into the community, ministry was in great strife trying to find ways and means to contain it, because we have a public health issue, and on the other hand, the macroeconomic weigh-in was quite heavy through our various politicians. Quarantine initially was dedicated to hotels. However, because the hotels became rather full and there was nowhere to go, home confinement started when there was a widespread sort of spread into the community. Initially, screening was done and swabbing has been curtailed now, and it is only being undertaken for high-risk patients. So our contact tracing Fiji Care app, which was put in place, is really not effective unless we develop into a third wave at some point where the strategies need to change. Isolation, social distancing, and masking is being advertised and put to the public. However, the social distancing can be difficult and isolation can be difficult when 20% of your population is living in peri-urban squatter settlements. We have short-term lockdown strategies were put in place. However, what happened was there was a shortage of food. The powers in play were having great difficulty supplying food. And in fact, when it was uplifted, the virus won the race. It spread further beyond the borders. Food security is a major issue in our setting at present because people work hand to mouth. The unfolding challenges in the pandemic is that, as we stated just a few minutes ago, on containment and how we need to be able to mitigate a lot more satisfactorily. State parties' fiscal restraints have been in place. The budget was reduced by close to 30% in 2009, and all the infrastructure developments have had to be sort of curtailed. There's need to be able to reprogram these ideas and get things moving. There's been loss of employment of a significant amount of people. We are dependent on tourism, and livelihoods and earning capacity has been adversely affected. And of course, important food is raising the cost of living for people who need assistance. Utilization of personal retirement funds, use of long-term security is a question at present. And that would mean that effectively a lot of people, retiring folk, will have great difficulty because they will have nothing to fall back on. The private sector, NGOs, civil society have not been party to state party efforts. It is a feeling of government that they can handle things on their own. The public health sector has not been called in full force to support, and even there's been failure to supply donated PPEs and other material to the private sector. the continued international vaccine diplomacy, which had a slow uptake, and additionally adversely affected by the anti-vaxxers. However, the numbers have improved somewhat in the recent weeks. If you look at the future challenges, I think these are areas which we really need to give thought as an all of society measure. Urgent healthcare strengthening of facilities is needed. Our supply chain of medication and consumables is important. Our technology is in need of upgrade and servicing, and our human resource needs to be optimized. We have focused very firmly on the COVID, and we've let things loose on NCDs, which is the largest killer. And additionally, things on health, if you look at health literacy, I don't think our general Pacific literacy levels are high enough for people to understand health literacy as such. There is need for greater public awareness. We need to address the microeconomic issues whilst sort of factoring in the macroeconomic issues. Food security, well-being, and livelihood are all affected. We need to consider adult dosing, booster dosing, as is being done in developed countries now. That needs some countries consideration. Vaccine strategies for 16 and 17-year-olds need to be considered as they turn into adults. We need to question whether children's vaccination will be needed in due course as they return to school, and future health and general health educational measures need to be considered while we scale up health services and social services funding. Finally, excess deaths need to be sort of put in place measures to be able to see where we are this year and what it will be next year. Death classification training and of medical personnel is much needed, and the current classifications they just take in direct and associated deaths, and we need to see what's happening to the non-COVID deaths in this country. Thank you very much.
Okay, thank you, Dr. Sharma. That was a fascinating presentation, insight into the COVID situation in Fiji. So now I'm looking for some hands or questions for Dr. Sharma. Anyone? If there's no questions, I'm going to keep looking through for questions. I essentially want to ask one about the impact of lockdown, distancing, and masking strategies, and how they're actually going on the ground from your perspective.
Thank you, Colin. In fact, what's happening, it's nice to see after the first wave that when the initial masking was ordered and social distancing, that was just not being followed. But with the impact of the second wave, we are seeing a lot more people being masked. There are now fines, spot fines if you're not wearing a mask in public. But if you look at people shopping and things like that, nobody's really following the 2-meter distancing. So that's an issue. Now, isolation, as I said, if you look at the people who really need it, our peri-urban squatters, if you have 4, 5, or 6 people living in a single bedroom, in a 2-room lintel house, it's hard to mask. You have to get out there and do some work today to put food on your table next day. And when you come home, you interacting with all these people. And some of our patients, personally, I'm in practice at present. I lost 4 patients. And basically, caregivers used to come in, or family members used to come in and provide care for elderly people. And they brought in the infection. So, it was unfortunate. These were long-term senior citizens of ours, and they just perished.
Thank you. We have a question from Sidhana. Please go ahead.
Dr. Sharma, you were a minister in the Fiji First government not so long ago. The Fiji First government in Fiji is aggressively marketing to open our borders to let tourists in December, or that's what they're saying at least anyway. How confident are you that our medical facilities are ready to receive our visitors? Because when you speak to, I mean, even when you speak to the diaspora, and I'm talking my relatives in Sydney, you know, that their big worries, oh my God, you know, we don't really want to come to Fiji if we don't really know how ready our hospitals are. In your opinion, are the Fiji medical services, hospitals, etc., ready to receive our visitors in December?
Thank you for your question. It's a very strategic one, in fact. We are rushing in to try and keep our economy running. However, our health facilities are very fragile. And, you know, sort of the supply chain of medication is not active. Our equipment is broken down. It needs to be serviced, refurbished, and new ones purchased. And, you know, the health workforce is under a lot of strain on extended hours of work. So, you know, sort of one needs to be cautious about the fact that you're going to be receiving visitors. And if you're not going to be able to provide the healthcare, then, you know, that's put the travelers and visitors at great risk. However, the people are talking about, you know, sort of quarantined areas and ensuring that the hotels are, you know, clear of any infection, that the workers in the hotels are vaccinated fully. But we must realize, you know, everybody must realize that, you know, even with your vaccination, you can still receive the infection. You can still spread the infection. All the vaccination does is it prevents you ending up in hospital or in a body bag. So sometimes it's a very difficult question. And I must profess I'm no longer part of the government. And, you know, sort of I have some concerns about it.
Thank you. We need to move on, but maybe one last question from the chat. Marion's asked, have cases mainly been in urban, peri-urban areas, or both urban and rural?
The cases were largely confined to Suva, the central division. However, with you know, opening up of the local borders, it has spread throughout Viti Levu. They've spread out on some of the maritime areas. Some of the islands are affected, and there are a few cases on the other island too.
Well, thank you again, Dr. Sharma, for the great presentation, and thank you for the questions. Let's move on now to Shane and Natalie for their presentation.
Great, thanks, Colin, and good afternoon to everyone, and welcome. I'd like to start off by presenting a general overview of the COVID-19 situation in Papua New Guinea, looking at both the current situation as well as looking back to the beginning of the pandemic and the trends since then. So if we look at the first slide, that shows us a number of figures, and these are all posted on the government webpage, the COVID-19 webpage in PNG, so updated figures. If we look at the total cases, you can see there, this is from 4 days ago, and this is just under 19,000 cases. In the last couple of days, this has risen to just over 19,000 cases, so cases are continuing to rise. It is, however, generally accepted that these figures are greatly underreported in the country. If we compare these to global figures, they seem to be quite low. And there are a few challenges in country which are the reason for a low number of total case reporting. These include a low testing rate countrywide, very low rates of testing throughout the country. And there's also a delay in reporting times. This is particularly from the more remote provinces as well. Once the PCR tests are done, it takes a while for these to be reported into a central statistics office and for those to be portrayed online. The first case of Delta variant was reported in the middle of July in Papua New Guinea. This was actually reported as an imported case. It came in through the port in Port Moresby via the sea. It was, however, identified early. Isolation was done early, contact tracing was done early. And initially, it appeared that these cases were being controlled and fairly well controlled. But subsequently, what we've seen in early August is that there are reports of increased cases in the border provinces. And these are particularly up around West Papua. So it's the Western Province and West Sepik cases. And we're seeing cases beginning to emerge there recently. So although this slide indicates that the number of Delta cases is reported to be 30, again, this is believed to be greatly underreported. The main challenge here, of course, is that genome sequencing is not available in country. There's currently no laboratory or public health laboratory in country able to do samples for genome sequencing. So any suspected samples are sent off to public health laboratories, either in Australia or in Singapore. And as we know, with the impact in Australia and the impact that they have on testing in their public health laboratories, this results in a delay of results coming back to PNG. And this can be up to 2 weeks or even longer than 2 weeks for us to get results of whether it's a Delta case or not. So there are reports of increasing case numbers and deaths due to COVID-19 in the border provinces, and this is overwhelming the public health facilities in these provinces. It's impacting an already struggling infrastructure, and the challenges are there in providing medication, consumables, equipment, and even staffing in these areas. In particular, we look at challenges around oxygen supply to these remote provinces to help support the cases and give oxygen to those who require it. Over this time, since Delta has been breaking out in the country, there have been no restrictions to domestic travel or lockdowns during this period. This has resulted in an increase in cases being seen in some of the other provinces as well, particularly the National Capital District, which is where Port Moresby, the capital, is based. This is because all the flights come through Port Moresby and onto other provinces from the highly impacted provinces. What we're seeing is both the public and private health facilities in Port Moresby are currently reporting an increase in the number of patients with respiratory symptoms that are presenting to their hospitals, and they're getting increase in the number of PCR positive cases. As I say, not necessarily identified as Delta, but certainly PCR cases and positives are going up. Subsequently, it's also resulted in an increase in the number of admissions at these hospitals and an increase in critical cases as well that are being reported. Earlier this week, on Wednesday this week, the National Control Center released a strategy. It's designed as a roadmap to deal with the current outbreak. It includes some recommendations for containment to be implemented in 4 phases. The first phase is currently underway, the planning phase, but it comes into effect next week. And we're waiting to see the final results, but it will last until at least the end of the year. It will include the release of new pandemic measures for us to follow in country. There will be encouragement of the non-pharmaceutical interventions as well. There is the talk around domestic travel restrictions and other lockdown strategies, in particular affecting those provinces with high case numbers and high Delta numbers that have been identified. This is also in the wake of gatherings in country from last week, which were to celebrate the country's 46th Independence Day on Thursday last week. And those occurred throughout the country at all provinces. So again, the concern that we have is around what we see globally and certain super spreader events that might occur. If we move on to the next slide, it shows the trend of COVID cases in PNG since the beginning of last year, 2020. And what can be seen there is, initially PNG did not have such an impact. We see a very small first wave, which was evident in August last year with a couple of cases. This was followed by a break until the end of the year, where there were a few cases in December. And what we see is a large wave starting at the end of February this year. And this is considered to be the second wave. And that lasted until the beginning of June, when case numbers began to drop off in country. What we can see from this graph, although it's a little bit outdated from the beginning of this month, we can see another rise in cases that are starting at the beginning of September. And this is generally believed to be the beginning of the third wave, and certainly within a Delta outbreak that we seem to be experiencing at the moment. So in early March of this year, there was an initial donation of 8,000 doses of the AstraZeneca vaccine from Australia to PNG. International SOS was approached to open up a vaccine center in PNG, and we started with the PNG Prime Minister, Mr. James Marape, who got his first vaccination at the end of March. This was a highly publicized event, and this was in an early effort to combat vaccine hesitancy in country. And at that stage, a number of high-profile people came in to get vaccines, as well as frontline healthcare workers, essential workers, and subsequently has been opened up to anyone who's over the age of 18. A team of over 50 national staff members, 60% of whom were women, were trained up to deliver the vaccine in PNG. And PNG then received further AstraZeneca vials and supply from the COVAX program. Initially, another 132,000 doses arrived in April of this year. And the PNG government, working closely and in conjunction with WHO and UNICEF, began a program to roll out the vaccine delivery in all of the 22 provinces. This included some remote regions with obviously all the logistical challenges that are associated with a program of this size and this nature. Since then, there have been further AstraZeneca donations from various countries, New Zealand included. And recently, Papua New Guinea has received a supply of the single-dose Johnson & Johnson vaccine, and distribution of this around the country has also begun. However, despite the access to these vaccines, and the next slide will show that the vaccine rates throughout the country remain very low. In terms of reaching the targets set for 2021, the highest uptake is seen in the more populous province, which is NCD and Port Moresby. And that had early access to the vaccine, and Western Province, which has reported high case numbers. The remaining 20 provinces all show first dose vaccine rates under 10% in relation to the 2021 targets. I'm now going to hand over to my colleague, Dr. Natalie Bray, to discuss the challenges associated with vaccine hesitancy in country.
Thank you, Shane, and good afternoon, everybody. So as Shane said, in PNG, as in most countries where the vaccine has been rolled out, vaccine hesitancy has been one of the biggest barriers to actually getting vaccine shots into arms. There are a number of reasons why vaccine hesitancy is so high in the PNG context. So obviously, COVID vaccines are new vaccines. People have a lot of very genuine and legitimate questions about what are they, how do they work, what's in them, why have they been developed so quickly, and how do we know that they're not going to have long-term side effects? So just like these questions have come up internationally, PNG was no different in people having these very genuine need for additional information about the vaccines. It was also a little bit tricky in terms of the time of the start of the rollout of the vaccine in PNG, because as Shane said, it started with AstraZeneca vaccine, and this coincided just with the time that a lot of countries were starting to say, we're not going to use AstraZeneca as our preferred vaccine in younger age groups. And of course, PNG has a young age demographic because of the risk of this extraordinarily rare clotting syndrome. Now that then creates additional questions around, well, why is this the vaccine that we are going to be using when other countries are not? There are obviously clear reasons for this, but it just demonstrates that the need and the thirst for information was extremely high at the time of the vaccine rollout. Of course, another driver of vaccine hesitancy is misinformation. So I'm sure all of you have heard all of the conspiracy theories that have surrounded the various COVID-19 vaccines. I won't go into them, but the information and misinformation on social media was extreme. And one of the really interesting things about vaccine hesitancy in PNG is about where people were accessing their information on social media. So Digicel being the main supplier of telecommunications in PNG, most people's plans allow them to access social media platforms like Facebook and WhatsApp, which are both great, but not the best sources of excellent information about vaccines, for free. But as soon as they started looking for more reputable websites targeted towards providing good information about the vaccines, those websites require data to be used and therefore started costing money. So there's also these inbuilt systemic drivers of why misinformation is so easy to access, which obviously feeds further into vaccine hesitancy. And then, of course, vaccine hesitancy is also driven by all the factors we understand so well around low literacy rates, low health literacy rates, information being provided overwhelmingly in English rather than local language, and the lack of access from that perspective. And of course, a vastly geographically dispersed population where access to printed or audio-visual information or face-to-face information is enormously variable. At the time the rollout started, this was combined with the fact that the COVID rates were still quite low and the hospital system wasn't overwhelmed. This was a matter of people seeing other diseases creating impact in their communities, not seeing COVID creating an impact in their communities. This is obviously changing now, but that acting as a, I guess, disincentive to come forward and get vaccinated as soon as they were eligible, with a lot of people either not seeing it as important, not seeing it as important as the things they would need to miss out on, for example, work, to invest the time to get the vaccine, or just wanting to wait and see how everything pans out. So an important part of delivering a vaccine program is the communication strategy around it. And there are a number of different ways that vaccine hesitancy was addressed in this context. Obviously, as you can see from this slide, the provision of information. That has different targets. So the more detailed information, questions and answer formats that might be targeted towards health workers who can then provide one-on-one education to communities, as well as sort of printed material infographics, which have the dual purpose of both educating, but also promoting the benefits of the vaccine. There was a documentary that was made called Life in the Ward, which is currently being screened. We didn't make it, we did contribute to it, which again aims to look at the path of the pandemic through PNG, what some of the barriers to vaccination are, what the benefits are, and why vaccination is good for you as an individual, but also for communities. And these resources, which are not just in English, but also translated into Tok Pisin, hopefully start to build some information and reassurance for people who are able to access printed and audiovisual materials. But as well as just providing information, we actually wanted to demonstrate through leadership that important, respected, and influential people within the community think that vaccination is a good idea and intend to be vaccinated themselves. So this vaccine awareness community leaders series was a series of television and social media clips where people from the church, from government, from sport, and from the human rights activism perspective could talk about what vaccination meant to them, why they felt it was important for their communities, and why they intended to get the vaccine. Ruth Kissam, who was one of the interviewees, also had the amazing insight of having been in New York at the beginning of the pandemic and was able to talk about what it was like when case numbers, hospitalizations and deaths were very much out of control, to try and get an idea across of what the pandemic may look like in the future in a PNG context. It's important to recognise too that vaccine hesitancy is not just something that happens to other people. Our own staff also had their own questions and their own elements of hesitancy. And by working closely with those staff, we actually had the opportunity to educate, reassure, and give staff the confidence to go forward and become advocates for vaccination, both within the course of their work, within their own families, and within their community. Which of course then brings me to that sort of one-on-one, that group community education, which is so, so important. So this is a picture of an education session happening at Wabo village, which is a remote village in Gulf province, where it's really just a matter of not expecting people to have to access information, but taking that information to people and being able to address the responses they have in real time. This was done both through community education sessions and also through the interviewing, not just of community leaders, but of representatives of different sectors of the population who could explain why vaccination was important to them. So cleaners, teachers, ambulance workers, all had the opportunity to talk about why they thought vaccination was important. And I have a very short example here of a Vox Pop with a teacher, if Ari were able to play that.
Judy Towne. I work at Busara International School. As part of the profession of being teachers, we have students come to us, so it's important that we protect ourselves and be safe so that we can be able to teach children in a safe environment. Instead of closing schools and stopping students from going to schools and being educated and let the normal routines of life go on, it would be good if we are all vaccinated as frontline workers so that we can be able to continue what we are supposed to be doing. We had doctors come to our school to give us an awareness of all this, so we've been prepared. I think I'd encourage people to come forward, read the real sources where this information is from about COVID-19 rather than going on social media and creating fear, I probably would say. But yeah, for my family, they're happy for me to come here, and I'm looking forward to sharing with them that information, and I look forward to this vaccination being open to the public so that my family can come and be vaccinated.
Thank you. Just quickly go back to presentation. So essentially what we've tried to do in the course of the program is to take the data, feed that into vaccine delivery, but then also look at how the communication strategy is so important. Because if we don't have people actually wanting to get vaccinated, we can have all the delivery programs in the world, but we're still not going to get those important vaccination rates up. So thank you for listening, and be keen to hear if you have any questions.
Okay, great. Thanks, Natalie. I'm looking for some hands, some questions. We're a little behind. Stephen, please.
Thanks, Colin, and thanks to Shane and Natalie for that important update. I mean, it was quite interesting that number for NCD for the vaccination rate was quite high. That's quite encouraging. But on the other hand, I mean, how much of that is expats getting vaccinated? I mean, so do you think we should be encouraged by the NCD results, or is it more something special circumstance?
Thanks, Stephen. I think that's a great question, and yes, it will be a combination of expats as well as, you know, as I said, from high profile. It's opened up to everyone now, and it is based on 2021 rates, target rates that they're looking at. So it is expected to be higher in NCD. There's been more drive. It was earlier access to the vaccine, and obviously communication around the important side, as Natalie mentioned, around education has been much more prevalent in centres like Port Moresby. So we expected those numbers to be higher. You know, as I did with a comparison, the numbers are much lower in more remote areas.
Okay, thank you. We might move along given timeframes, but thank you for that very detailed and insightful presentation, Natalie and Shane. So I'll ask Simona and Aya if they'd please like to present.
Okay, I think I'm unmuted. Good afternoon, everyone. Lucky last session, last day. Fortunately, it's some good news, I think, and a return to the old foe, the NCD crisis in the Pacific. So my name is Simona Achitei. I work with DT Global in Adelaide, and I'm joined by Aya Vang from Nairobi. A very, very early good morning to Aya, and I'll let her introduce herself.
Yeah, hi everyone. My name is Aya. I work as a senior associate at an organization called Busara. Yeah, we're based in Nairobi, so that's why it's dark at my windows, in case anyone was wondering.
All right, so I know we're a little bit behind on time. What we want to talk to you about today is three things. Firstly, the program or the innovation in tackling NCDs in the Pacific. It's a new approach to an old foe. So we'll talk a little bit about what it is before Aya will talk to you a little bit about what they have been able to find out and research as far as its effectiveness over the past 3 years. And lastly, it will come back to me and I'll talk a little bit about what all of that means with reference particularly to Pacific regional economy, costings, the financial cost, but also the human element of that. Before we get into it, I guess because you're in the audience today, you have a strong understanding of the impact of the NCD crisis in the Pacific. And I don't need to get into that too much, but I do want to say that the expenditure in health costs over the last decades to prevent, treat, manage NCDs has been significant. So this continuous rise in cases and in impact is happening despite the very significant investment made in this area. For example, the Australian government has spent over 190 million AUD in the last decade on prevention for NCDs across our 4 countries. I'll talk about that in a second, what 4 countries that is. And there's been a ceiling of 750 million in total ODA health costs from the government of Australia, which is the main funder, as we know, in the Pacific. So no progress really, no positive impact so far in this area. Enter the Pacific Island food revolution, a very innovative new approach to tackling NCDs in the Pacific. It is the brainchild of celebrity chef and international development practitioner Robert Oliver. He has worked on this for many years before it was picked up as a pitch and funded by the governments of Australia and New Zealand 3 years ago. What is it? It is a social and behaviour change communication program that takes an innovative, evidence-based, culturally grounded approach to tackling NCDs. Its signature piece is a television program that where contestants from Fiji, Vanuatu, Samoa, and Tonga compete against each other using local cuisine. Ingredients are sourced from local sources, specifically addressing the barriers to healthy eating. And it's all underpinned by the Pacific Island Food Revolution, or PIFA, a nutrition framework, which was developed by SPC at the outset. In addition to TV, we have radio programs in local languages across the 4 countries. There has been an outstanding, I would say, exceptional social media campaign and presence across the Pacific and beyond, and more traditional community engagement activities, which in light of COVID, of course, have not gone ahead to the extent that we had thought. The ultimate goal here is for Pacific people to routinely choose healthy, local, nutritious food, contributing to improved well-being by 2030. So what is the innovation here? There's the edutainment form that this takes using multimedia, common mass media, multimedia, communication platforms that people already use, combining that with behavior science insights, which tells us why people make the decisions, irrational often, that they make each day, combining that with that element of science, and then trialing a new way to message about healthy eating. So it's a positive spin, if you like, on that. Now, being that it is multimedia, it would be remiss not to show you a little bit of a taster, and it won't be long, don't worry. What to say, the first minute and a half or so has got some content filmed on local phones and so on. It explains a little bit the concept and why food is the entry point here. And then the second half of what I'm going to show you, the second minute and a half, it gives you that taste of what the very high quality product that we have had streaming now for 3 years across the Pacific and beyond looks like. There are captions in case sound is not too good.
Food is central to Pacific life. Most of our activities in the rural communities and farming communities evolves around food.
Diabetes, cancer, hypertension, heart attack. One of the 4 main contributing factors to all NCDs is unhealthy nutrition.
Far too many children in the Pacific are either overweight or underweight. They're either eating the wrong foods or they're not eating the good nutrition that's right in their backyards.
Imagine right now we are amputating limbs 1 in every 8 hours. So therefore, we are producing 700 disabilities a year. People don't embrace local foods because of a few factors, strong marketing by processed foods manufacturers and producers.
Most Papua New Guineans really love their greens. I think the problem is that the actual access to it and perhaps even the expense of it, especially in the larger towns like Port Moresby.
My continuous hope is that people embrace fresh food and local cuisines. It has helped sustain our forefathers. They lived longer lives because of that.
When someone valuable is taken out of a societal structure because they're sick, this is when societies start to falter.
If children don't get adequate and appropriate nutrition in the earliest years of their lives, they will not be able to develop their fullest potential, and they won't be able to contribute to their own country, their own societies, their own communities. Literally, the stake over the Pacific is at stake if we don't change these issues.
The food and cuisine is quite simply the best in the world.
They'll cook for renowned judges and create dishes that bring Pacific Island cuisine into the spotlight, where one team will be named the Pacific's Best, Pacific Island Food Revolution.
What I love about the Pacific Island Food Revolution is its ability to connect to Pacific peoples through food. It speaks to individual cultures, individual islands in a way that no other program has used before.
We're looking at food as a solution to the NCD crisis. The NCD crisis is just a symptom of a food culture that's slightly off its own tracks but can easily be brought back onto its tracks.
I definitely see the opportunity for the Pacific Island Food Revolution to work in other sectors apart from health, particularly economy, social cohesion, attitudes of young people to their environment, that kind of thing.
I wanted to be involved with the program because, the answer to our problem lies in our own countries with our local foods.
When there's an episode of Pacific Island Food Revolution playing, it may last a certain amount of time. But the time that's spent discussing the episode, discussing the food, I think that's a key component of Pacific Island Food Revolution as a development tool.
Okay, hope that's given you a taste. There's much more available online, of course, and you're welcome to have a look and check out the website. Before I hand over to Aya to tell us a little bit about evidence and impact to date that we've been able to see. So there's been a 3-year pilot funded since 2018. In these 3 years, we have moved from an idea, a concept on a piece of paper to a fully implemented program implemented in 4 countries, as mentioned before. We have produced 2 full TV seasons distributed across 12 Pacific countries via 20 TV networks. The second season was distributed at prime time after the news. We have reached about 5 million people out of a total population of 12, obviously far beyond our 4 countries. We have also been distributed and can be found also in Australia, New Zealand, the whole of Asia, the UK, and more recently the US. This being quite important from tourism and local agriculture development purposes, assuming that tourism can indeed open, whether later this year or into the future. I was mentioning earlier, in addition to TV, we have an exceptional social media presence. We know social media is quite a platform, very powerful platform, particularly for urban environments, but not only. Just looking at Facebook, the numbers here are actually real. We've reached in 2020 just about half the population of the Pacific, 5.6 million. And of those, over 600,000 have actually engaged with the content, meaning, shared, commented, etc. to what they've seen. We've been on 4 local radio programs in our 4 countries. That's been really important from reaching diverse audiences perspective, so expanding from urban to peri-urban, rural and isolated. We have also done community engagement, as said, to a lesser extent, and we have shared and developed 100 recipes. We're using easy, accessible, local ingredients for people to use. Before I hand over to Aya to start talking about M&E, just worth noting, Busara has been our monitoring evaluation partner, our behaviour science partner right from the beginning. The investment in monitoring evaluation learning on this program has been significant right from the beginning, and rightly so. This was an experimental approach. Everything else had failed in the past. People are a bit suspicious of using traditional mass media platforms to tackle something as significant, important as NCD. So we really had to know, is it working? How is it working? Can we improve it? And how do we build it? And is there something here to continue to invest in? So Aya will focus primarily on the latest report that we've done and result, but we've done more than that, including a midterm independent review commissioned by DFAT. So Aya, over to you.
Yeah, thank you. So as Simona was saying, Busara, and we are an independent research organization. We've partnered with DC Global and PIFA since 2018. And as you can see, we've done a lot of different research activities. One of them was a lab study, which we did at USB campus in Suva, with over 800 participants from Fiji, Vanuatu, Tonga, and Samoa. And that gave us an opportunity to run a causal study because it was before PIFA aired, so we could control who watched PIFA and who didn't. And here we actually found compelling evidence that watching PIFA instead of a control show led to improved food choices after watching. That was quite exciting. So the most recent study is our final impact assessment, which is the one I'll be focusing on today. Next slide, please, Simona.
That's all right.
So the impact assessment study, it builds on previous findings, and basically it aims to provide more evidence as to whether watching PIFA actually is associated with shifting diets away from unhealthy foreign foods towards healthy local food. So now, given PIFA has been widely accessible, as you saw before, we're not in this study randomizing in the same way as we could before, but instead we're looking at correlations and associations between engaging with PIFA and a range of dietary measures. So we, of course, also had to add some sessions focusing on COVID, and understanding how the pandemic has affected PIFA's opportunity to impact dietary behavior. Next one. So to complete the study, we worked with 4 local organizations, and some of you may know them. So Further Arts in Vanuatu, Kokonu in Tonga and Samoa, and finally Salt Inc. in Fiji. And our process had these 4 phases. We started out with the partners to co-create an instrument for quantitative data collection. We surveyed a total of 330 people. We then presented those findings back to the partners, basically to discussions and for us to understand it better. And that led to the last phase, which was then in-depth qualitative interviews, just to shed light on some of the outstanding questions there still were. Next one. So just starting out with our key dependent variable, which is engagement with PIFA. So we'll link all the findings back to this one. So here we asked respondents whether they follow PIFA. That was to include both TV, social media, and radio engagement, if they had only heard of PIFA or if they hadn't heard of PIFA at all. And as you can see, a very high share of respondents across all countries have either followed or heard of PIFA. Next one. And next one, please, Simona.
Yeah, sorry, it's stuck. Aha.
Yeah. So what we do now, which is the key part of the analysis, is that we basically take this engagement data and we create a variable that we call seen PIFA. So this is based on having watched at least 2 episodes of the show and being able to clearly explain the purpose and content of the show. So anyone who doesn't fall into this category, we call them not seen PIFA. So basically we're creating these 2 subsamples, which we then compare on some different measures. Next one, yeah. So our first finding is that having seen PIFA, which you can see here as the blue bars, is associated with positive shifts in diets across all 4 countries. So the question here was whether they believe their diets have changed in the past year, and if yes, then how so? So then because we didn't want to ask a leading question, of course, we had to manually go through the data and store all the responses who specifically said towards more local and healthy food. And we find that between 12 to, We find that between 12 to 31 percentage points more of those who've seen PIFA than those who have not have improved their diets. And as you see percentage increases here, you see that Tonga and Samoa are above 200% increase. And that's because very few of those who had not seen PIFA had improved their diets in the past year. So next one. Interestingly, when we then put these 2 graphs together, we see a quite clear correlation between countries where respondents have watched more PIFA, also experienced relatively larger improvements in diets. Next one. Last finding, from a behavioral science perspective, really interesting finding, is that watching PIFA is associated with generally believing that local food has become more popular over the past year. So that indicates that PIFA can influence this perception of social norms, which we believe is a key step for behavior change. And finally, looking at the effects of COVID-19, we have to mention it. We wanted to understand how pandemic has affected dietary behavior in the environment that PIFA operates in. And we find that overall, the pandemic has actually created a conducive environment for PIFA's goals. Some of the points you can see under yes. In Tonga, however, we saw that government kept prices down on foreign food through price controls, which makes it even more interesting that we saw the biggest relative improvement in Tonga between those who have watched PIFA and those who have not in their diets. And that makes us believe that PIFA is able to positively influence dietary behavior, even when external environment is not necessarily conducive. Back to you, Simona.
Thank you, Aya. Lastly, just what does it all mean, this impact assessment after 3 years of program? Is it looking promising? Yes. Do we have some statistically significant numbers there? Yes. It's more than that, though. What we think is happening is quite a large movement afoot that is taking place across the Pacific. PIFA is part of that, but obviously it's not the sole solution. It's part of the solution, however. The COVID environment is a really interesting one and a positive one for PIFA and for PIFA combating NCDs. Firstly, it has been resilient to COVID, unlike other prevention programs. Community engagement face-to-face have been impacted, but TV, radio, social media, not at all. In fact, they've flourished. But in addition to that, what COVID has done is that it has created a real favorable environment for people to actually understand, internalize, and act upon the key messages of PIFA. In many ways, it's the best time. Maybe it's the only time that tackling NCDs in this manner can succeed in a way that we haven't seen before. Now, numbers and money do matter. I've tried to have a look at what has been the impact of NCDs on local economies in the Pacific, focusing on our 4 countries. Really difficult to extract numbers from individual budgets, as that numbers are buried in different lines and so on. But we've looked at broader international studies, and the most conservative estimates we found is that for NCD treatment costs alone, that's estimated at between 2 and 4% of GDP across Pacific countries. Now, if you put that dollar numbers on that, we're looking at somewhere between $135 million to $275 million per year. That's according to the World Bank numbers. Now, According to the Busara study, after 3 years of programming, we are looking on an average of 42 to 43% of people across our 4 countries who have watched PIFA or engaged with PIFA and have shifted their behaviour towards positive, healthy, nutritious food. What we've looking again at GDP numbers and treatment costs alone, what we have found is if only 1% of the population across our 4 countries do change their diet for the better and sustain it over a period of 1 to 5 years, then PIFA will have delivered net economic benefits to the Pacific. I'll show you where this comes from. It's a pretty simple way of calculating using NCD treatment costs again. So looking at that treatment cost, what that means, what that costs to the local economy in 4 countries, looking at the PIFA estimate. So what you will see after 5 years, at 1% of individuals changing their behavior and avoiding NCDs, the net benefit to the local economy will be around 3.8 US million. That looks like 20 million if we can get 5% of individuals to sustain that change over 5 years, and it's over 45 million US again if we can get 10% of individuals to sustain that change over 5 years. The numbers are significant, and this is only NCD treatment. This doesn't count the cost of mortality, of death, of injury, the cost to communities for what NCDs create in their wake. Also, this doesn't count the impact that PIFA has had, not just in 4 countries, but there's 12 countries across the Pacific that are tuning in every week. PNG is our 2nd largest audience, I believe. And it's not even a focus program country at the moment. So this is could be quite exponential. And it's not all about numbers, it's also about people. So using the same projections, we've looked at the number of people that could be positively impacted, assuming 1, 3, 5, 10% of people, of audiences across our 4 countries maintain that change. So in 5 years, we can positively impact 5% of the population of these 4 countries and over 10% in 5 years. So again, think about more than treatment costs, think about everyone else who's accessing it, quite significant. And the end. Thank you very much. Open for questions. I'm sure there'll be many.
Oh. Thank you, Simona and Aya, for that presentation. I'll just move quickly to the questions. So Judy Houston has a question saying that there'll be other factors that contribute to less NCDs in the shifting diet. Is PIFA claiming attribution or purely contribution to positive behavioural change?
Yes,
and
no,
Aya, do you want to expand on your response?
Yeah, sure. So yeah, like the way we're presenting our findings, we are comparing those who have not watched and those who have watched PIFA. There's absolutely other factors affecting, but we do believe that those other factors are likely to affect you equally, whether you have or have not watched the show. And that's why we don't focus so much on the absolute values between the 2 groups, but we focus more on the relative differences.
Okay, well, if there's no more questions, and I think we're slightly over time, we might wrap it up here. But I just wanted to thank our panelists, Dr. Sharma, Stockil, Dr. Gray, Simona and Aya for great presentations and a really interesting session. So thank you very much.
Thank you.
Thanks, everyone.
Thanks, thanks, Colin. 3 really interesting papers with co-focus on COVID-19 and NCDs. I think it's clear that the pandemic has challenged the national capacities to prepare and respond. What has also emerged from the presentations is that policymakers and the wider public have to be aware of the relationship between health systems, community engagement, domestic economies, including governance structures. So let's thank all our presenters virtually one more time. Thank you all. This brings us to the end of this session. It also concludes Pacific Update 2021. Last year, we couldn't have the update due to uncertainties, as Professor Stephen Howe's told us yesterday. So it's great that we are able to bring it back this year, although it's in online format, but I'm sure those who attended have enjoyed. We were able to listen to a number of great presentations. We both ANU and USP, we are hopeful that we'll be back in Suva next year for an in-person update. And I take this opportunity to thank our co-organizers at the Deaf Policy Center, Beth, Ari, Ryan, and Stephen. Thanks for all your hard work. And finally, thanks everyone for attending. And we hope to see you all at the update in Suva next year. If it was Suva, we would have ended this session with a nice cover session. But unfortunately, I had some of the participants messaging me that they have some cover in their cupboard somewhere. So please, after you go back, you can mix some and assume that you are sitting in Suva. So once again, thank you everyone, and Vinaka Bakalepu.